35-year-old female. She has a sudden onset of shortness of breath after she's cleaning the house. She's attempted multiple home rescue inhaler uses prior to calling you. She's alert and oriented. Her GCS is 15. Airway's clear. You know a lot of use of accessory muscles. She's tachypnic with very quiet lung sounds. Her skin is pale. She's quite sweaty. She's got that periorbital oral cyanosis. She's hypotensive in the 80s. She's tachycardic. Her respiratory rate is 42. She's only satting 88% for us. And that's on a duoneb at 6 liters per minute. She's only speaking about 2 to 3 word sentences, extremely anxious. Well, I don't blame her. This sounds terrible. So let's think about this woman. Think about our lemon law, our Roman, our rods, and our smart. Looking at her, just kind of a drive-by view. I don't see any anatomy that would make me suspect she'll be an anatomically difficult airway. So let's get a little bit more into the reactive airway diseases. These patients can be very hypercarbic. They can have air trapping. They can be very hypoxic. And these are some of the patients who love to crash on you as soon as you intubate them. So what is the clinical challenge with asthma and COPD? So they have some co-founders. Hypoxia, even once you get the sats up, they're going to desaturate very quickly, and they can be hemodynamically quite unstable. Now remember, these patients may worsen after you intubate them. So you're not out of the woods per se just because you have an airway in place and you have a confirmed placement. These patients often have respiratory acidosis. They may have barotrauma. They may have a pneumothorax that can convert to a tension pneumothorax. They often will become hypotensive because of all of this increased intrathoracic pressure. So keep a very close eye on these patients after you intubate them. So here's our clinical approach. Optimize before we intubate them. So you never want to jump in and intubate an asthmatic, a crashing asthmatic, without trying to optimize them. And remember, this is all happening pretty quickly. We're still getting set up for intubation. We're still pre-oxygenating the patient. But while we're getting everything ready, we're also treating their underlying physiology. So we're giving them lots of albuterol. Just flood them with albuterol. Nebulize anticholinergics, so give them that ipratropium. Solumedrol, give this early because this is going to work. This helps quite a bit. You may not notice it before you intubate, but this may reduce some of the inflammation after they're intubated and help with oxygen exchange. Fluids, 30 cc's per kilos to replete all of this hyperventilating that they're doing. They're just blowing off all of their fluids. Not to mention, giving them fluids will help optimize their blood pressure. Some other things you can consider as well is giving them a magnesium drip, 2 grams, or 25 to 75 milligrams per kilogram. Ketamine with CPAP. So a lot of these asthmatics will benefit from CPAP, but they have a hard time tolerating it. So giving the lower dose of ketamine to facilitate the CPAP can be really helpful. Or you can even give it as a DSI, so giving a 1 to 1.5 milligrams per kilogram of ketamine and doing CPAP to pre-oxygenate before you induce them or before you paralyze them. And then don't forget, you'll always have epi. So epi is a strong bronchodilator. This is a great medication for asthmatics who are crashing. It can give some bronchodilation. And it gives some pressure support as well. You can do push dose for pressure support. You could do a drip too. So remember that these patients have a lot of air trapping, and this starts before we intubate them and that continues after we intubate them. So if you haven't taken these steps to optimize them and you get them intubated, you haven't actually fixed any pathology. So the pathology is they can't get the air out. So they're sucking the air in actively and they're pushing the air out actively when they're awake. But when you intubate them and you paralyze them, they are no longer able to push the air out. So for every breath you push into their lungs, hardly any gets out. So you need to allow time for exhalation. And don't forget, as you increase the intrathoracic pressure with all of that air trapping, your blood pressure drops. So it is very common for their blood pressure to drop after you intubate them because you have increased air trapping. And remember, there's a little trick for these patients that when you ventilate them, after you squeeze the bag, take the BVM off of the ET tube so that the air can flow out passively, because it has more resistance trying to go through the BVM. So allow for a long exhalation period with the BVM off. So since we mentioned DSI, let's review this one more time. So ketamine is the induction agent of choice for DSI. Etomidate can make people stop breathing and often does. So always use ketamine if you're doing DSI. It can be helpful in the asthmatic because it can help tolerate pre-oxygenation, but also ketamine has a nice side effect of bronchodilation. So anytime I have a patient with a reactive airway, I definitely want to give them that extra bronchodilation from the ketamine. So essentially, we're delaying the administration of our paralytic for a good 3 to 5 minutes. And this is to get them nice and pre-oxygenated, wash out the nitrogen as best we can. Once we give the paralytic, we will intubate as normal. Now, don't confuse this with sedation-only intubation. I've seen a little bit of an increase in people intubating people without paralytics because they're thinking DSI means, well, let's sedate them and take a look. That's not what it means. It means you sedate them for the procedure of pre-oxygenation, and then you give the paralytic before you perform laryngoscopy. Whenever you're intubating an asthmatic or a COPD patient, give and use the biggest ET tube you can, because smaller ET tubes have more resistance and you're going to have more difficulty with the exhalation. It's not the air going in that's the problem, it's the air coming out. So try to use an 8.0 or even a 9.0 ET tube if possible. Little recap here. So you have a patient that you're going to perform DSI on. First, you dissociate them. 1 to 1.5 milligrams of ketamine. You can add a little bit more if it's not quite enough. You're going to pre-oxygenate them. At a minimum, they're getting flush rate, non-rebreather. If their SATs aren't over 95, you should be trying the CPAP. If they're not ventilating, meaning rate or volume, you may use a BVM with PEAP. Be cautious with that PEAP valve when you have air trapping, though. Paralyze them. Sucks or rock, equally fine. APOX, don't forget your nasal cannula. 15 liters per minute is kind of the classic teaching, but we're starting to move towards flush rate on this too. And remember, use the biggest ET tube you can. So, post-intubation management. So after we get our reactive airway patient intubated, we want to reverse hypoxia. We want to increase the ventilation volume, so get a nice big breath in when you ventilate, but decrease the rate. So we want to oxygenate them with a nice full breath of high flow, 100% oxygen, but we want to allow time for them to exhale. So our inspiratory to expiratory ratio is 1 to 4 or even 1 to 5, so really nice slow breaths here. And again, remember, take that bag off the ET tube to reduce resistance as the air is coming out.